Good day, everyone who have attended this session. And this is Pavan from Enliven Archive and Gnome Publications. And we are conducting this webinar as we are having outbreak over here. And we want to share our knowledge to each and everyone. And this session will be taken by Dr. Subhrojyoti Bhowmick, MD,
Bhowmick,
FISQUA.
Dr. Bhowmick,
Yeah,
Dr.
okay.
Subhrojyoti Bhowmick. Yeah.
Okay, sorry. So, Dr. Subhrojyoti Bhowmick has done his MBBS with specialization in clinical pharmacology, and he have 13 years of experience in patient safety, clinical quality, and hospital accreditation in Indian and US hospitals. He is certified in patient safety from Johns Hopkins University, USA, and certification in clinical trial administration from Stanford University, USA. And he is founding president of the Patient Safety and Clinical Quality Forum of Kolkata in January 2018 and chairman of IAC Health Point Hospital, Kolkata. And he was an academic director for Master of Hospital Administration course at Peerless College of Hospital Management, Kolkata. And he is the winner of the International Society of Healthcare Quality Lucian Lee Patient Safety Fellowship Award for 2019. This is a very honorable thing because he's first Indian doctor to receive this prestigious fellowship. Fellowship in Healthcare Quality from International Society of Healthcare Quality, Ireland, UK, and Senior Research Associate at Stanford University School of Medicine, USA for over 2 years are other added features of Dr. Shobhrajyoti. Coming to his conquers, there were many and many more. And coming to his professional experience, he was selected for 3 months assignment and pay on patient safety at WHO, that is World Health Organization, Geneva, from September 2019 to November 2019, and volunteer staff part of Lucian Lee Patient Safety Fellowship Award from World Health Organization, Geneva. And Peerless Hospital, Kolkata, India, as a clinical director in academics, quality, and clinical research since November 2017 onwards. He had attended many international conferences and published a lot of international peer review articles in open access and subscription journals also. And there are many more things that can be discussed about Dr. Subhrajyoti, and we are very honored to be collaborated with him. And he is one of the editorial board members of our journals in Noma publications. And currently, he will be delivering his speech on current COVID-19 infection that covers pharmacological therapies in COVID-19 infection. I would like to welcome you to the session, Dr. Subhrajyoti. Please hand over your presentation to us.
Yeah. Are you able to see the presentation which I'm pulling up?
Yes, yes.
Okay, so thank you for that round of introduction and good afternoon, everybody. I think there is a lot of webinars happening on a day-to-day basis on COVID-19, and you must be bored, if I'm not wrong, to come to another webinar. But today's webinar is with a bit of difference because today's webinars we are going to understand about what are the pharmacological therapies. That means what are the different drugs which are available for the treatment of COVID-19 infection. I would like to begin with a disclaimer that this is as per the available data in the published literature. And as of now, till today, WHO has not approved any drug which is considered the drug of choice for COVID-19 infection treatment. So whatever I will be discussing over the next 30-35 minutes are basically whatever research information are available for these pharmacological therapies in COVID-19 infection across the globe and also in our country, India. So if we look at the beginning of this disease, this is we know COVID-19 is being caused by a novel coronavirus which causes severe acute respiratory syndrome, which is also known as COVID-19. It has emerged first in the city of Wuhan in China in December 2019. And as I speak now, more than 29 million cases have been reported, and over 2 lakh deaths have been reported in more than 200 countries. So it's a pandemic, which has been declared by the World Health Organization as well. So we have been asked to practice social distancing at home, follow guidelines like regular hand washing, wearing masks, and just to break the chain of infection, because we still don't know what is the absolute therapy. A few words about the virus. It's COVID-19 or SARS-CoV-2 is a single-stranded RNA enveloped virus, and it enters through the viral structural S protein and binds to the angiotensin receptor on the cells. After receptor binding, the virus enters the host receptors and uses endosomes to enter the cells. And once it enters into the cell, there is viral replication of the protein by the enzyme replicase transcriptase, and it synthesizes its own RNA with the help of RNA-dependent RNA polymerases, and it takes structural protein from the host cells and forms many daughter cells, and ultimately explodes the host cells and comes out of the host cells. So the virus causes rapid destruction of the host cells, and it is more concentrated in the nasopharyngeal cells and in the alveolar cells, and also in the cells across, I would say, the nasopharynx and across the lung. As a result of which, many of these patients are developing acute respiratory distress syndrome, and they are dying. So these in pharmacology, the various steps are actually promising drug targets, and because we have to understand how the virus enters into the cell, and anything which can block it are their drug targets. So possible drug targets could be the non-structural proteins which share homology with other, like for example, 3-chymotrypsin protease, RNA-dependent RNA polymerases. So any inhibitors of these enzymes can function as, I would say, a good drug therapy. And there could be other drug targets, including something which can block the viral entry and which can produce immune modulation of the regulation pathway. This is a nutshell of how the virus enters into the cell. So I mentioned it uses angiotensin receptor and enters, and once it enters, there's membrane fusion and release of the RNA, and the RNA replication and packaging happens. And once the packaging and the replication happens, the virus takes with the help of the RNA-dependent RNA polymerases, generates its own RNA, and with the host cell is explodes out of the surrounding into the surroundings. So what is the world doing when there is an absence of drugs? How is the world looking to treat these patients? Majority of these patients are being treated with the help of repurposed drugs. What is the definition of a repurposed drug? That means a drug which is being used for some other reason is now being repurposed, or its new indication is being tried in COVID-19 infection. So basically, these agents were tried for when there was an outbreak of SARS and MERS around 5 to 10 years back, and meta-analysis of these drugs which were used for SARS and MERS found no clear benefit in the COVID-19. So in the next few slides, I will talk about whatever the published clinical experiences have been. These can be in the form of non-randomized trials, or they could be in the form of observational studies of promising COVID-19 drugs, which can be approved by the US FDA or our Indian regulator to become the drug of choice for COVID-19. The first drug I want to discuss is hydroxychloroquine and chloroquine. So hydroxychloroquine and chloroquine have a long-standing history. In fact, hydroxychloroquine has been used for a long time for the treatment of malaria and chronic inflammatory diseases like SLE and rheumatoid arthritis. So what is the data against COVID-19? So in vitro studies have shown that is the in vitro studies, the studies outside the human body, they have shown that both chloroquine and hydroxychloroquine appear to block viral entry into the cell by inhibiting glycosylation of the host receptors, proteolytic processing, and endosomal acidification. And also, hydroxychloroquine appears to play a very important immunomodulatory effect, and this is particularly important when in the COVID-19 infection, because some percentage of these patients go into what we know as cytokine storm, which is releasing of lot of cytokines into the body, resulting in the body is trying to destroy the COVID-19 virus. Along with that, because so much of cytokines are released, there's destruction of the host cells as well. So this cytokine storm results in massive ARDS, adult respiratory distress syndrome, and eventually patient lands up in the ventilator and then the patient dies. So the entire pathophysiology of this immunomechanism going wrong in cytokine storm is supposedly I would say one direction in which hydroxychloroquine is working. It has been proved in the in vitro model as well. Hydroxychloroquine has in vitro activity against. It has more in vitro activity against COVID-19 virus, vis-a-vis chloroquine, and among the toxicity profile, hydroxychloroquine is better. So what is the data which is available? So you have publications which are not randomized control trials. Let me tell you, we still don't have randomized control trials from hydroxychloroquine. There is no high quality trial, is what I mean. There is a news briefing from China which reported chloroquine was successfully used for treating 100 COVID-19 cases, resulting in improved radiological findings, enhanced viral clearance, and reduced disease progression. But we are still looking forward to a good clinical trial. These two drugs are not very safe. They are toxic drugs. So and if you remember, if you just to make you understand that many of the guidelines are saying that we must use azithromycin with hydroxychloroquine, because it has got a better viral clearance in COVID-19 patient in comparison to the monotherapy. Hydroxychloroquine are well tolerated, and majority of the side effects are usually, I would say, one of the few side effects of hydroxychloroquine. Number one could be there will be gastric intolerance. So, some of the patients, of course, you have to be very careful because it can cause cardiac rhythm disabnormality, and we have to be very careful on these things. Other significant adverse effects for chloroquine are more, and usually the chloroquine and hydroxychloroquine is generally considered safe in pregnancy. So there is a very recent meta-analysis which has been performed last week. Hydroxychloroquine was found to be effective in vitro against SARS virus. There is, I would say, a systematic and meta-analysis using RevMan was conducted to evaluate this alone, and it said that probably with the use of hydroxychloroquine, the time to clinical cure is better than not using hydroxychloroquine. Here, I would like to highlight the role of prophylaxis by hydroxychloroquine. What is prophylaxis? Prophylaxis means you give the drug to the patient, or to close suspects before the infection happens. So, for the viewers who are watching this webinars, please understand that the Government of India through ICMR has recommended prophylaxis only for high risk cases. That is, one is for the healthcare workers, people who are taking care of patients. They should take this hydroxychloroquine as prophylaxis, 400 milligram BD twice daily on the first day, followed by 400 milligram. No, I think there is a mistake on the slide. It will be for the next 7 weeks here. 400 milligram BD on day one, followed by 400 milligram once a week for 7 weeks for the healthcare worker. But for the close contact, it is 400 milligram BD on day one, followed by 400 milligram once a week for the next 3 weeks. Here, I would like to highlight that it is not for routine consumption. Not anybody and everybody can take this hydroxychloroquine because it's a relatively toxic drug. You should always take this under medical supervision. Go to your doctor, speak to him, get your ECGs done, and then only you should take the prophylactic dosing. Else, you should not be using because it is only recommended by ICMR for healthcare workers and close contact of positive patients. So somebody comes positive in your house, so you become a close contact. So in that case only. The other drug which is showing a lot of, I would say, potential is ivermectin. It is approved by the FDA for parasitic infection. It's widely available due to inclusion in the WHO model list of essential medicine. Ivermectin has previously shown a broad spectrum antiviral activity in vitro as an inhibitor of causative against the COVID-19, but these are again in vitro. That means outside the human. In a study, it was found that single addition of ivermectin causes 5,000-fold reduction in viral load. So in within 48 hours. So this is definitely a molecule which has a lot of potential, and there is recent review and meta-analysis indicate that high dose ivermectin has comparable safety as low dose treatment, and this is being tried out in clinical trials. So ivermectin clinical trials in COVID-19 have also started. The other very important drug which is showing a lot of potential is favipiravir. It's a pro-drug. That means it is taken in active form in the liver. It gets into an active form of favipiravir, furosemide triphosphate, 5-triphosphate. The active agent inhibits the RNA polymerase, halting the viral replication. So if you remember my first slide where I showed that the virus, once it comes out in the host cell, it requires an RNA polymerase, RNA-dependent RNA polymerase to generate more copies of RNA for the daughter cells. So favipiravir is actually a good agent which inhibits the RNA polymerase and it halts the viral replication. And there's a lot of positive reports. In fact, a clinical trial has been reported from Japan that favipiravir has done remarkably well in mild to moderate COVID-19 patients. And the government of Japan is trying to approve it on a fast track basis. Further investigations are of course on in India. Favipiravir is trials are supposedly going to start from next month. To the best of my understanding, Glenmark is one of the companies which is going to undertake trials with favipiravir. Now going to other antiviral drugs, lopinavir and ritonavir. Lopinavir and ritonavir is a US FDA approved oral combination for treating HIV, and it has shown in vitro activity against novel coronavirus. There is no published in vitro data for lopinavir and ritonavir. Clinical studies were associated with reduced mortality and intubation rate, but they're actually retrospective in nature. So there is no prospective study. So the US FDA currently there is a large study which is going on in the United States on lopinavir and ritonavir combination in COVID-19 patients. Um, but I would like to add here that lopinavir and ritonavir has been recommended by certain countries, including India, for severely ill patients when they cannot tolerate hydroxychloroquine. In fact, in Russia, lopinavir and ritonavir has been approved for mild to moderate treatment. We know that these drugs are not without a lot of side effects. The adverse effects are lopinavir of these combination drugs include gastrointestinal distress, nausea and diarrhea and hepatotoxicity. So we have to be very careful when we are using these kind of drugs. Drugs and drug-induced hepatotoxicity is of particular concern because it may exaggerate underlying liver injury, which can result from COVID-19. So I think we have to be very careful when we use this combination lopinavir and ritonavir. Ribavirin is another guanine analog. It's an antiviral drug. Ribavirin, it inhibits viral RNA-dependent RNA polymerase, and its activity against novel coronavirus makes it a candidate against COVID-19. However, its in vitro activity against the novel coronavirus is very limited, and it requires very high concentration to be used. So much so that you might have to dose 2 grams every 8 hourly for this combination. Patients have received either intravenous or enteral administration in previous studies, but still now there is no evidence which exists for inhaled ribavirin in novel coronavirus infection. And the data is primarily with ribavirin. The good data is there with respiratory syncytial virus with inhaled administration, and but still the data is lacking in COVID-19 infection. So ribavirin, what are the common side effects? It produces dose-dependent hematologic toxicity, and it also produces hemolytic anemia. So we have to be very careful when we're trying to use ribavirin in COVID-19 infection. Oseltamivir. This was the magic drug in the last outbreak of swine flu. Oseltamivir is a neuraminidase inhibitor approved for influenza, that was swine flu, but it does not have any documented activity against COVID-19 infection. The COVID-19 outbreak in China initially occurred during peak influenza season, so a large proportion of patients received oseltamivir until it was discovered that this novel coronavirus was a different virus altogether. Because initially, when the patients are coming in the hospital in China, they thought that it was a resurgence of swine flu and oseltamivir was given. There are current clinical trials are ongoing with oseltamivir, but still we don't have clear-cut data. But I would like to add to this that the WHO guideline on patient management does mention that if the patient comes in with a lot of signs and symptoms of running nose or blockage of nose, or the patient is coughing a lot, sneezing a lot, then oseltamivir is indicated to be given in the initial treatment days, even if it's a COVID-19 patient, because it has got an important role in reduction of the influenza symptoms. The other drug is obifenavir, is a more promising repurposed antiviral drug with unique mechanism of action of S protein angiotensin interaction. So this S protein is on the coronavirus, and the angiotensin receptor is on the membrane, is on the host membrane. The agent obifenavir is currently approved in Russia and China for the treatment and prophylaxis of influenza, and is on increasing interest for treating COVID-19 infection based on the in vitro data against SARS. The current dose is 200 milligram every 8 hourly, and it's being studied now in clinical trials. Some other agents, interferon alpha and interferon beta, have been studied for novel coronavirus, with interferon beta demonstrating activity against MERS, because interferon beta had a good data against the Middle East respiratory syndrome. Most published studies reported results of therapy combined with ribavirin and or lopinavir ritonavir. However, no animal or human data exists to recommend their use for COVID-19 infection. So we still have to be, we cannot just use interferon beta left and right, and it's still not approved. Nitazoxanide is an anti-helmintic drug with broad antiviral activity, and it has demonstrated in vitro antiviral activity against the MERS virus and the COVID-19 virus. And pending further evidence, antiviral activity, immunomodulatory effects, and safety profile needs to be further studied. ACE inhibitors, I think there was a lot of controversy in ACE inhibitors, whether they should be given, they should not be given. Initially, it was found out that patients receiving ACE inhibitors for hypertension reduction, there was an initial thought process generally in the United States that patients were dying more, but this is not correct, because as per the European Society of Hypertension, they should be continued. The patients who are on ACE inhibitors should be continued. In fact, angiotensin receptor blockers could theoretically benefit by blocking of the angiotensin receptors, and this was in conflict to the in vitro data. which came in the initial part of when the Americans were experiencing a lot of cases. Remdesivir is a monophosphate prodrug and undergoes metabolism to form an active C-adenosine nucleoside triphosphate. Research and development of the agent showed promise against Ebola virus and is still being tried. In fact, Gilead is developing remdesivir and clinical trials are on in the United States and China to see remdesivir's efficacy and safety in COVID-19 infection. So we still await the publication of that clinical trial results with remdesivir. There is one of ongoing trials. There is one of particular importance where in the United States there is a National Institutes of Health is sponsoring an adaptive randomized double-blind shared effectiveness of remdesivir comparing the supportive care. As a result, from the RCTs the RCTs of remdesivir is still going on, as I mentioned. It is still not an FDA approved, but then we are getting positive data about remdesivir in COVID-19 infection. This is the list which is available from the clinicaltrials.gov of the ongoing, I would say, ongoing clinical trials and with the different drugs in COVID-19 infection. So I have already discussed the majority of them. What about the other drugs like corticosteroids? There was initially rationale that corticosteroids should not be used because it aggravates ARDS, but now more and more evidence is coming in, especially with methylprednisolone, that corticosteroids should be used and it improves the patient outcome. So this we still clinical trials are undergoing, but with methylprednisolone, for say, there is direct evidence generating now that COVID-19 patients are getting improvement. There is a recent retrospective study in China with 200 patients that found out treatment with methylprednisolone reduced the risk of death to 46%, where vis-a-vis to 62% who did not receive that. So the potential harm and the lack of proven benefit for corticosteroid cautions against their routine use. It should not be used routinely. But however, because the study which has been reported, the retrospective study, we need a longer study, a prospective randomized clinical trial to say with confidence that whether this drug whether corticosteroid, especially with methylprednisolone, is effective or not. There's some role of anti-cytokine or immunomodulatory agent, and especially because with this cytokine storm, which I mentioned, which happens in many of the patients, the rationale for the use is that once the cytokine storm produces significant organ damage, revival of the patient becomes very difficult. One of the drugs which is leading the list in this is tocilizumab, a monoclonal anti-leukin 6 receptor antagonist, is FDA approved to treat rheumatoid arthritis and cytokine release syndrome. The cytokine release syndrome happens in COVID-19, so indirectly, tocilizumab is being used in many patients of COVID-19. In fact, if you go and search the web, you will find that there have been a couple of case reports of tocilizumab being used in the treatment of COVID-19, and the patient has cured. The other drug is sarilumab, is another anti-interleukin 6 receptor antagonist, and has been studied, is undergoing a phase 2, phase 3 trial in severe COVID-19. Immunoglobulin therapy, a potential candidate for COVID-19, is the use of convalescent plasma or hyperimmunoglobulin. In fact, the United States, the FDA is seriously thinking to undertake a clinical trial. In fact, it has started a clinical trial with the convalescent plasma. The rationale is that the treatment with these patients who have recovered, they have antibodies against the COVID-19 virus, which may help which will help the destruction of the free virus in cases of patients who are infected with COVID-19. So there are anecdotal reports or protocols for convalescent plasma used as salvage therapy previously when the swine flu outbreak happened in SARS and in case of MARS. And on March 2020, the FDA has released a guidance for requesting an emergency investigation of new drug application for screening of COVID-19 convalescent plasma. Um, the other thing I would say is WHO also recommending, WHO of course mentioning on March 13 that there is no current evidence to recommend any specific COVID-19 treatment for patients with confirmed COVID-19. So everything I told right now is they're all under investigation. So they are still, we have to wait for the clinical trials to complete, and they recommend they should these drugs, of which only the Indian government recommends hydroxychloroquine. If you look at the Indian Ministry of Health, the government guideline, if you see that it has recommended hydroxychloroquine with azithromycin, and in very severely ill patients where the when hydroxychloroquine cannot be used, it has recommended lopinavir ritonavir combination. Finally, I would say that the WHO has started a mega trial, which is the Solidarity trial with the pragmatic trial design. And the idea is to randomize patients into either four arms. One will be remdesivir arm, chloroquine arm, or hydroxychloroquine arm. The third arm will be a ropinavir ritonavir, and the fourth arm will be ropinavir ritonavir plus an interferon beta, and then we see what is the outcome of these patients. So to conclude, I would say that the COVID-19 pandemic represents the greatest public health crisis of this generation since 1918. Because 1918 there was this Spanish flu which killed millions of people, and though I would say the mortality rate is not so bad, but still a lot of the already a couple of lakhs of people have died. The speed and volume of clinical trials, the only good thing differentiating Spanish flu with COVID-19 is that there are a lot of pharma companies now, and the government is now, many of the governments are now trying to speed up clinical trials so that potential therapies could be investigated and a drug could come out at the earliest possible time, and we can use it on patients. But the take home message is that there are still no therapies which have been shown to be effective against COVID-19 infection till date. This is my reference. This is a paper which I would recommend everybody to go through. It's a paper by Sanders, JM, and it's been published in the Journal of American Medical Association. The full text is available. It talks about the pharmacological treatments for coronavirus disease in 2019. It's a very good paper, and I've taken my information from this particular paper along with the WHO website. So with this, I would like to end my presentation. Over to you.
Yeah, Dr. Subhrojyoti, there is a participant, Mohsina Patwekar, had appreciated your presentation. He is an assistant professor from pharmacology. He says that it's nice information about the drugs. And I would like to convey that from participants, if you have any questions, you can just put over in the chat option, or you can just raise your hand so that I'll make you speak over through the speaker. If you have any questions, please then and there you can either raise your hand, or you can put over in the chat option. And meanwhile, I have a question, Dr. Subrajyoti.
Mhm.
Yeah, is there any sector concentrating on stem cell therapy, or is our stem cell therapy will be useful for this COVID 19, treatment or something?
See, everything right now is very speculative. Okay, so yes, there are a few couple of medical research which has been done with stem cell therapy, especially in Israel. They have worked on pluripotent stem cell when they wanted to generate if there could be antibody generation, especially the antibody generation against COVID-19. But yet, I would say that there are still no concrete publication in a peer-reviewed journal has appeared So we cannot say that that is an active or that is an effective, I would say, effective method of treatment. But people are trying out, and unless and until a government agrees to it, that means a regulator, either the US FDA or the DCGI, we cannot still accept it as the effective modality of treatment.
Okay, there is a participant, Prasad Koka. He wants to ask a question.
Yes, please. Has he asked? I'm not able to hear him.
No, he haven't appeared yet.
Okay.
Dr. Prasad Koka, you can just talk over. Prasad Koka, can you just put your questions? I have provided you the mic. Can you please? Yeah, please come in.
Can you hear me?
Yes, Dr. Koka, please tell me.
Yeah, Dr. Bhowmick, can you hear me?
Yes, I can hear you. Yes.
Can you hear me? Yeah, okay. Uh, this cytokine storm, uh, the thing is if the elderly patients, elderly infected patients, uh, or I mean, if they have lower levels of immunity, how is it that they would be eliciting a stronger cytokine storm, or is it that because they are not, because they are unable to elicit a, an appropriate cytokine storm, they are failing, their immune system is failing?
No, that's a good question which you asked, Dr. Koka. I think there are two different things. One is having lesser immunity. That means when you have lesser immunity, so you don't prevent the initial colonization of the virus. So when the virus is trying to colonize you at nasopharynx or at the alveolar cells, so these elderly people, because they have other comorbidities like diabetes or hypertension or COPD, their cells are not functioning as normal cells, and as a result of which the colonization and the incubation becomes easier for the virus. The virus can easily enter into these cells. The second part of it is when people have when the virus infection has infected the an elderly patient who has got diabetes. In them, they are triggering off the cytokine storm, and not only I would say in any in only elderly patients, but any patients where you are seeing patients who are undergoing ventilation. So this is why you will see there's a wide spectrum of clinical presentation. 80% of the patients will only have mild symptoms. And in 15 to in 15, 10 to 15% of the patients, they might have coryzal symptoms. 5% of the patients will go into cytokine storm. And these 5% of the patients who are going into cytokine storm, one of the pathophysiology which is being recommended or being mentioned in these articles or the published literature is that the body itself cannot differentiate between what is my own cell and what is an viral cell. So it's like an autoimmune disorder in these 5% of the patients where the more and more amount of antibodies are coming out and triggering off the cytokine storm. So it's a dysregulated immune response which is happening in these 5% of the patients in COVID-19 infection. And that's the result that this drug, hydroxychloroquine, is being recommended by majority of the Ministry of Health because apart from having its different action at the entry level or at the acidification of endosome, because hydroxychloroquine has been used as an immunomodulator, and majority of the patients who undergo a cytokine storm, have massive destruction of their lung tissue and the alveolar cell to reduce this cytokine storm, hydroxychloroquine is being recommended. That's one of the reasons why this drug has been formed. So, elderly patients, I think, or patients who are going into ventilation, or I would say patients who are having ARDS. That's the underlying factor is cytokine storm, and to control this, the reason why honestly it's not very well known why only 5% are having cytokine storm, why the 95% are not having it. One of the recommended things is that the body is this is behaving like an autoimmune disorder.
I have two more questions. Another one is, um, do you think that the medicines that are used to control typhoid based on the Vidal test uh, would have any role to play here?
No, I don't think so, Dr. Goka, because typhoid is caused by Salmonella typhi. It's a bacterial disease, and usually the drug of choice in typhoid is the penicillin, amoxicillin, or I would say, in patients who don't respond to amoxicillin, clavulanic acid combination. The other classes of medications which are used, these are all antibacterial drugs. They have not shown any in vitro activity against COVID-19, which is a viral. So we actually have to have those drugs which are number one to begin with should be antiviral by nature, and number two is even if they are not antiviral by nature, like hydroxychloroquine is not antiviral, they should be antiparasitic by nature. But as you mentioned, the typhoid fever, it's caused specifically by Salmonella typhi, which is being treated, which is a bacteria. So these are two different classes.
Okay, thank you. And one last question. There are trials going on uh, by a group in somewhere in southern United States, UNC and University of Georgia or something collaboration. Uh, they have
Boston, I guess.
identified those drugs as ED 1391 and ED 1201 or something. I may be wrong with the numbers. And uh, they have they have I mean they are thinking that is better than remdesivir, has some advantages. This particular antibiotic. Do you have any knowledge of that?
Yeah, see, as I mentioned, there are like currently there are more than 100 clinical trials which are on. And if you see the coding, these codings are all done by the pharmaceutical company to for intellectual property type.
Did you hear my question?
Sorry, did you say something?
And
Hello?
the drug, I reports. Can you hear me?
Yeah, I can hear you. So you mentioned about
Yeah.
remdesivir. Remdesivir, the entire information, remdesivir trials are being undertaken by Gilead Life Sciences in the United States. As of
No,
now, there, sorry.
they the trials are. I'm talking about the trials on ED 1391 and
No, I
ED.
am not. I am not very sure about the drug which you are referring to because there are multiple such molecules which are in use. The one which I showed in my presentations are the one which have progressed to at least phase 3 or they have proved anti-COVID-19 activities in vitro. So I'm not sure about the one which you are referring to.
Okay, thank you.
You're welcome.
That's all, Prasad Koka. Yeah, and there are a couple of questions from Mohisina Patwekar. He asks that what is the prescribed drugs for the patients in quarantine? As you said that hydrochloroquine is taken under medical supervision.
So currently there is no prescribed drug for patients in quarantine, number one. So, but you have to understand with the ICMR advisory, it says that if you are in quarantine if somebody in your family, close contact has come positive, then the ICMR advisory says that you can take hydroxychloroquine. So if so, somebody, God forbid, if somebody in my house comes positive and I've been living with that person, that makes me a close contact. So I am a very close contact for that patient. So in that case, the ICMR guideline is very clear. I will take hydroxychloroquine, 400 milligram BD on the first day, followed by 400 milligram once daily for the next 3 weeks. This is very very important to note that if I am only a close contact and I am undergoing a quarantine, then only I will take it. If I am not a close contact, that means if some of my colleague has come positive and I might have just spoken to him for 5 minutes. So the cutoff time is 15 minutes. You should have exposure for 15 minutes, more than 15 minutes, not wearing a mask. Both of them should not wear masks. So effectively, if you are wearing a mask, a surgical mask. Both the patient as well as you have been wearing mask, and the interaction has been less than 15 minutes. Ideally, you need not go for quarantine. Also, you need not go because it has to be for a substantial period of time. Your exposure is required. So if only if you are a very, very close contact and you have been advised to go for quarantine, you are at home quarantine, then under medical supervision, yes, Dr. Mohsina actually mentions that the importance of medical supervision, absolutely. We should not start hydroxychloroquine and hydroxychloroquine becoming now H1, schedule H1 drug. Nobody can sell hydroxychloroquine. It's illegal to sell hydroxychloroquine without a prescription. So you have to have a registered medical practitioner whose prescriptions have to be there, and he has to decide depending on number one, that you don't have any cardiac problem. Number two, you don't have any ophthalmological problem. You should not have any retinopathy. And number three is you should not have any history of G6PD deficiency. If you have history of hemolysis, then you should not be given this drug. That's the reason a registered medical practitioner evaluation and decision is so important.
And he also asks Sir, tell something about the replace patient.
I'm not very sure what is this replace. Is she asking about the relapse?
Maybe that I'm sorry, that's relapse. That's a typo.
Yeah, so relapse, I think that till now there is no WHO has not confirmed, has not confirmed information about that COVID-19 cured patients are undergoing relapse. There are there is few information in the media which is available in the media and the WhatsApp that in certain countries relapse has been noticed. But WHO, the official stand of WHO right now is that they are still, it's a new disease, you have to understand. It's only 3 4 months old. They are still evaluating patients who have been cured, and they have not come with a clear cut guideline or a guidance that relapse happens in this patient population or not. 5 minutes, relapse or not. So I think this question we have to really wait and watch for the WHO to come with guideline and guidance.
So you say that there is no confirmation, like there is nothing like we'll we'll have relapse or not. It's not confirmed.
So what I am saying currently, Dr. Kumar, is that we have to go by what the World Health Organization issues the advisory in terms of relapse. Currently, there is no official advisory which says that relapse is happening in COVID-19 patients. There are some data, and I will name the country South Korea, especially from South Korea, that some of the patients are reporting as positive. But we also have to, once they have become negative, they are coming back with positive. We also have to understand that the procedure in which the sample collection is done. Because I told you, majority of these patients will not have any symptoms. In India, close to 80% of the patients don't have any symptoms. They are so the RT-PCR, which is pulling your sample and is diagnosing you as negative, might not have been negative. You might have pulled the wrong sample, and that's the reason that the patients are still showing positivity. So as of now, I would say there is no document, there is no advisory, there is no confirmation from the World Health Organization that COVID-19 is undergoing relapse, and we will stick by that.
Okay. And yeah, I guess there is one more. Dr. Koka have one more question. I guess he had raised his hand. I'm just handing over the mic.
Yeah, please go ahead.
Dr. Bombay,
Yes.
uh, it, do you think that the virus is mutating rapidly enough to make the antibody therapy ineffective, or the virus is not mutating as rapidly? Because there is a paper from Kolkata, which, I mean, I have read this on Times of India. They submitted
Uh,
that they found one dominant strain and
yes.
10 or 11 mutants. But are these mutants really very lethal, or do you think there's only one major strain going on?
Yeah, so Dr. Koka, this is only one paper currently which says that the virus has mutated. And the reason why this virus started, there is that people believe that it mutated from a strain in bat and it jumped species to come to human beings. Though many people believe that that is not true, something else has happened. But now currently that is what the World Health Organization is saying, that the origin was through a mutation, it changed into species, and from Wuhan it was very well controlled in Wuhan, but through travel it went to few European cities, primarily in the Italy, and there it underwent another mutation. So if you see the lethality which Europe has seen, especially the country of Italy and Germany, I would say Germany was less, Italy, Spain, and so they believe that there was a separate mutation there, and the variant which has come to India is less lethal, is what this paper is saying. I've read whatever this paper. I've also not gone through the full text, but if you look at the WHO stand, WHO has ruled out the possibility that the virus has currently undergone a lot of mutation strain, and the official stand of WHO is that it's the same mutant which has jumped species which is causing infections across the globe. So currently there's only one paper which is available from Calcutta, as you mentioned. Yes, from the Institute of Genetic Biology, which has claimed this, but I think more information, I would have to read the full text article to give a concrete answer to this.
But it is not anywhere like HIV, right?
I don't think so. No.
No. Thank you very much. Thank you, Dr. Pawan Kumar.
Yeah. Do you have 2 minutes of time, Dr. Subhrojit, or shall we end the session soon?
Yeah, we have to, because I have one of my colleague doctors, we are in the hospital, we are very busy, so we have to, it's better we can end quickly. I have to speak to one of my senior consultants.
Yeah, yeah.
Right.
Okay.
Yeah.
Definitely, definitely. I would like to deliver my word of thanks to all the participants and also Dr. Subhrojyoti Bhowmick for this wonderful session. And we belong to Enliven Archive Open Access Journals and also No Publications Open Access Journals. You can reach out for publication assistance to us. And yeah, we anticipate Dr. Subhrojyoti to continue his positive collaboration with NOM Publications and Enliven Archive for continuing issues and publishing papers. Please do promote our journal to your colleagues, to Dr. Subrajyoti. That is very happy and we are very proud to have you in our, in our editorial book. Thanks
Thank
a
you.
lot for
Thank you so
your
much.
Yeah, we are falling lapse of time. I'll be ending the session. Thanks a lot.
Thank you.
Thank you. Thanks a lot for your webinar.